Bismillahirrahmanirrahim. Quote of the day is: if money is your hope for independence, you will never have it. The only real security that a man will have in this world is a reserve of knowledge, experience, and ability. Assalamu alaikum. I'm Dr. Nabeela Umar, and today I'm going to present the topic of rabies under the kind supervision of Professor Dr. Saira Afzal. The learning outline of the topic: introduction, epidemiological determinants, clinical manifestations, levels of prevention, recent advances, and at the end, multiple choice questions. Learning outcome. By the end of this presentation, participants would be able to understand about rabies, its clinical manifestations, control and prevention of the disease, and various national and global updates on this topic. Introduction. Rabies is a viral disease. It is a highly fatal disease of the central nervous system. It is caused by a Lissa virus type 1. It is a zoonotic disease of warm-blooded animals transmitted by bites of rabid animals. It has a long and variable incubation period with short period of illness. It does not have any treatment, only prevention is present. Epidemiology. The agent of rabies is the rabies virus, which has a knob-like spikes, a glycoprotein G. It has an M protein layer. Its genome is unsegmented, linear, negative sense RNA. It stimulates the T lymphocyte cytotoxic effect, and it also has heme agglutinating activity. This is the structure of the rabies virus. This is the matrix protein. This is the host-derived lipid membrane. This is the glycoprotein G. This is the RNA genome helical coil. Now, what are the types of rabies virus? There are two types. One is the street virus and the other is the fixed virus. The virus recovered from the naturally occurring cases of rabies is called street virus. Its sources are the naturally occurring virus. It is found in saliva of infected animal. The fixed virus is the virus which has a short, fixed, and reproducible incubation period. It is prepared by repeated culture in the brain of rabbit, such that its incubation period is reduced and fixed. The street virus produces Negri bodies, while the fixed virus does not form Negri bodies. The incubation period of street virus is long, 20 to 60 days, while the fixed virus incubation period is constant between 4 to 6 days. Street virus is pathogenic for all the mammals. Fixed virus can be pathogenic for humans under certain conditions. Street virus cannot be used for preparation of vaccine, while the fixed virus is used for the preparation of anti-rabies vaccine. What are the sources of infection? The saliva of rabid animals. In dogs and cats, virus may be present in saliva for 3 to 4 days before clinical onset. The host factors are the all warm-blooded animals, including man. Rabies in man is a dead end infection. People at risk are the lab workers, veterinarians, dog handlers, and hunters. Mode of transmission. It is transmitted through bite of rabid animals such as dogs, bats, fox, etc. Exposure to aerosols of secretion or droppings containing rabies virus. Transmission in transplant of corneas taken from patients who died of undiagnosed rabies. Incubation period. It is normally 3 to 8 weeks, may be short, that is 4 days, or may be prolonged for years. It depends on the site of the bite, severity of the bite, number of wounds, amount of virus injected, species of biting animal, protection provided by clothing, and the treatment taken. Now, this is the pathogenesis of the rabies virus. First, there is an infection bite wound. The virus multiplies locally in myocytes for weeks or months. Then the virus travels up peripheral nerves to central nervous system, and in the nervous system, it causes encephalitis. The virus moves out through the peripheral and cranial nerves to various salivary glands, skin, mucosal surfaces, gut, most other organs. The saliva infected for several days up to weeks before signs appear, and then it causes the death of the patient. Signs and symptoms. It causes headache, fever, sore throat, nervousness, confusion, pain or tingling at the site of the bite, hallucinations, hydrophobia, which is that the patient is afraid of water. Even sight or sound of water disturbs the patient. It causes paralysis, spasm of pharynx produces choking, and it causes coma and death. Clinical stages of rabies. The first stage is the incubation period, which lasts for 20 to 90 days, and there are no symptoms and signs in this period. The second stage is the prodromal stage, which is 2 to 10 days. It causes fever, malaise, anorexia, nausea, vomiting, paresthesia, pain, or pruritus at the wound site. The next stage is the encephalitic stage, which lasts for 2 to 7 days, and it causes anxiety, agitation, hyperactivity, bizarre behavior, hallucinations, autonomic dysfunction, and hydrophobia. The next stage is the paralytic stage, which lasts for 2 to 10 days, and it causes flaccid paralysis in limbs, progressing to quadriparesis with facial paralysis. And the end, the stage of coma and death. Diagnosis. The primary diagnosis of rabies relies on clinical presentation and history of exposure to a suspect rabid animal. Now, what is a suspected case? A case that is compatible with the clinical case definition. A probable case is a suspected case plus a reliable history of contact with a suspected probable or confirmed rabid animal. And a confirmed case is a suspected or probable case that is laboratory confirmed. Rabies prevention and control. It has two components. Number one is the animal rabies control, which is a primary prevention measure used to prevent the disease at the source. The second is the human rabies prevention, which is a secondary prevention measure. Now, what are the elements of animal rabies control? It includes mass vaccination of dogs, movement restriction, control of stray dogs. Mass vaccination of dogs include the animal pre-exposure vaccination. For effective control, at least 75 to 80% of the population should be vaccinated. Should be done on regular basis. Movement restriction or confinement. If there is a suspect rabid animal, it is isolated and observed for at least 10 days. If the animal is exposed and previously vaccinated, it is quarantined for 6 months. Euthanasia of unvaccinated animals if exposed. If a person got bitten by a stray dog, the wound should be washed and left open for secondary closure. Measures for stray dog control. Create responsible dog ownership among the community. Dog restriction and identification. Environmental control, excluding dogs from sources of food. Humane dog population management, animal birth control. And euthanasia means the act of inducing death in a humane manner. Second is the human rabies prevention. Its element includes avoiding exposure, pre-exposure prophylaxis, post-exposure prophylaxis. Pre-exposure prophylaxis provided to subject at risk before occupational or vocational exposure to rabies. Subject includes diagnosticians, laboratory and vaccine workers, veterinarians, carers, etc. Simplifies post-exposure management. Only vaccines used. Since 1984, WHO has strongly recommended discontinuation of production and use of nerve tissue vaccines and the replacement by modern, concentrated, purified cell culture and embryonated egg-based rabies vaccine. Nerve tissue vaccines can induce severe adverse reaction more frequently and are less immunogenic than cell culture vaccine. WHO recommendations apply only to inactivated cell culture vaccine. Since the early 1960s, the cell culture vaccine have been administered to millions of people worldwide. Cell culture vaccines are intended for use in both pre- and post-exposure prophylaxis. All cell culture vaccines should comply with the recommended potency of more than 2.5 international units per dose for intramuscular injection. The rabies vaccine are currently available only in single-dose vials and do not contain preservative. Evidence support administration of cell culture vaccine by intradermal or intramuscular injection. A systematic review of vaccine potency had shown that the current vaccine, when administered by the intradermal route for either pre- or post-exposure prophylaxis, have efficacy equivalent to or higher than that of the same vaccine administered by intramuscular route. For the intradermal route, one dose is 0.1 ml of cell culture vaccine. The vaccine is in one vial can therefore be fractionated to provide 5 to 10 doses for intradermal administration depending on the vial size. For the intramuscular route, one dose in one vial of vaccine per patient. The concentration of antigen-presenting cell in the dermis is responsible for the strong immunological response to vaccine administered intradermally despite the lower amount of antigen injected. Intradermal administration of rabies vaccine provides a cost-saving and dose-sparing alternative to intramuscular vaccination. As number of patients seen in clinics increase, intradermal regimes become increasingly cost-effective, using up to 85% less vaccine vials. Now, there are two intramuscular schedules for the categories 2 and 3 exposures, the 5-dose regime and the 2-1-1 regime. Vaccine should be injected into the deltoid muscles for adults and children aged 2 years and more. The anterolateral thigh is recommended for younger children. Vaccine should not be injected into the gluteal region. The intramuscular regime for the rabies post-exposure prophylaxis, the 5-dose intramuscular and SN regime. One dose of vaccine should be administered on days 0, 3, 7, 14, and 28, given in the deltoid region or for young children into the anterolateral area of the thigh muscle. Intramuscular regime for the post-exposure prophylaxis, which is 211 Zegrab gene. The two doses are given on day 0 in the deltoid muscle, right and left arm. An additional dose is administered in the deltoid muscle on day 7 and day 21. Now, the intradermal regime for rabies. The intradermal regime requires a reduced volume of vaccine to be utilized than any of the intramuscular regimes, therefore reducing vaccine cost by 60 to 80%. The method is appropriate where vaccine and money are in short supply, particularly in rural areas and with high-flow clinics. Intradermal regime. The volume per intradermal site is 0.1 ml. Using the intradermal route for administration, PVRV and PCECV have been proven to be safe and efficacious. 0.1 ml per intradermal site is used according to WHO recommended intradermal regime. Vaccine administered intradermally must raise a visible and palpable bleb in the skin. If the dose of vaccine is inadvertently given subcutaneously or intramuscularly, a new dose should be administered intradermally. The second method is the two-side intradermal method. One dose of vaccine of 0.1 ml is given intradermally at two different lymphatic drainage sites, usually administered in the deltoid muscle on the left and right upper arm and suprascapular area. Given on the days 0, 3, 7, and 28, the day 14 dose is missed. The post-exposure prophylaxis is provided to subjects after rabies exposure. It consists of wound care, rabies immunoglobulin, and vaccine. Cleansing, chemical treatment, suturing, anti-rabies serum, antibiotics, and anti-tetanus measure, and observe the animal for 10 days. Wash the lesions well with soap and water. Infiltrate rabies immunoglobulin into and around the margin of the bites. Administer vaccine on days 0, 3, 7, 14, and 28. A series of rabies vaccine injections should be administered promptly after an exposure. Rabies immunoglobulin should be administered for severe category 3 exposures. Wounds that require suturing should be sutured loosely and only after rabies immunoglobulin infiltration into the wound. WHO recommends post-exposure prophylaxis for category 2 and 3 exposures. Now, what are the categories of the rabies exposure are? Category 1 includes the touching or feeding animals' licks or intact skin. The category 2 is the nibbling of uncovered skin, minor scratches or abrasions without bleeding. And category 3 include the single or multiple transdermal bites or scratches, contamination of mucous membrane, or broken skin with saliva from animal licks exposures due to direct contact with bats. If a repeat exposure occurs within 3 months of completion of post-exposure prophylaxis, only wound treatment is required, neither vaccine nor immunoglobulin are needed. According to the type of category, the recommended post-exposure prophylaxis, in category 1, no treatment is required if reliable case history is available. In category 2, wound management and anti-rabies vaccine is given. And in category 3, wound management, rabies immunoglobulin, and anti-rabies vaccine is given. Rabies immunoglobulin administration. Immunoglobulin provides passive immunization and is administered only once as soon as possible after the initiation of post-exposure prophylaxis and not beyond day 7 after the first dose of vaccine. Correctly administered, immunoglobulin neutralizes the virus at the wound site within a few hours. To confer the maximum public health benefit, WHO recommends the following. The maximum dose is 20 international units and 40 international units per kilogram of body weight. There is no minimum dose. Infiltrate as much as possible into the wound. The remainder of the calculated dose of immunoglobulin does not need to be injected intramuscularly at a distance from the wound, but can be fractionated in smaller individual syringes to be used for other patients. Requirement for rabies prevention and control should be backed by legal framework, allocation of resources, expand diagnostic service, surveillance system, skilled manpower, collaboration among stakeholders, community education, and participation. Recent updates. The World Rabies Day is celebrated on 28 September, and in the present year to 2024, the theme of the Rabies Day was Breaking Rabies Boundaries. This is a global call to highlight the need for cross-sectoral or cross-border collaborations, bringing together governments, health organizations, veterinary services, and communities. Rabies in Pakistan policies and recommendations. Rabies, commonly referred to as the endemic disease of the imperial in Pakistan. In Karachi, the yearly occurrence of rabies ranges between 7 and 9.8 cases per million individuals. Key challenges in Pakistan include limited awareness and increasing dog bite incidents. Implementing a One Health model encompassing mass vaccination, cost effective treatments, training on intradermal vaccine administration, accurate data collection, and community awareness initiatives is essential for rabies control. Concentrated efforts and more initiatives are required to reach a rabies-free Pakistan by 2030. Implementing large-scale animal birth control programs involving the capture, sterilization, vaccination, and release of stray dogs is crucial. Promoting responsible dog ownership is of paramount importance. Given that dogs are often found in areas abundant with food waste, managing household waste can help mitigate the population of free-roaming dogs. Dog bite awareness campaigns in educational institutions, particularly schools, can significantly reduce incidents among young people. Community awareness programs play a pivotal role in preventing human rabies, especially during disease outbreaks. Implementing population control measures for dogs should prioritize mass dog vaccination alongside target vaccination campaigns. It is imperative that every district hospital has access to cost-effective anti-rabies vaccine and facilities for managing animal bite wounds. Pakistan joins the Food and Agriculture Organization program for elimination of rabies. Pakistan has joined a program being carried out by the Food and Agriculture Organization of the United Nations for strengthening capacity towards the rabies elimination in Asia. Pakistan's government has requested the Food and Agriculture Organization for its technical assistance to provide dog vaccination and distribute communication materials related to rabies risks and how to mitigate them. About 2,000 dogs have been vaccinated and 100 dogs were neutered in the country. The survey of the dog population estimated the presence of 48,899 pets and 175 stray dogs in Islamabad. A total of more than 1 lakh dog bites cases in humans and more than 76,000 dog bite cases in animals were reported in the last 3 years. The Food and Agriculture Organization project report recommended that all countries continue supporting mass dog vaccination and accelerated dog population management and rabies control program. To achieve the target zero rabies transmission by 2030, the countries implemented the integrated bite case management system, delivered capacity building training session for government officials, veterinarians, public health experts, and laboratory technicians on rabies diagnosis, tools and techniques, sample management, data survey tools for dog population counting, and risk mapping of stray dogs for an effective vaccination program. Multiple choice questions. Number 1. Rabies is highly fatal disease of the central nervous system caused by Lissa virus type 1 and is associated with encephalitis and hydrophobia, leading to coma and death sometime. Which among the following is true for rabies? A. Rabies is not prevented by pre-exposure prophylaxis. B. The death rate is highest in the elderly. C. All the vaccines can only be used intradermally. D. Deaths have occurred post-transplant. Or E. Incubation period is very short, usually 4 to 6 days. The answer is D.
C.
Deaths have occurred post-transplant. MCQ number 2. A person XYZ was bitten by a stray dog and his next 3 days, he feels tingling sensations around the wound and unusual pain. He got frightened and came to nearby tertiary care setup. There he was given injections of immunoglobulin. Which of the following is best regarding rabies immunoglobulin? A. It is only manufactured as a human immunoglobulin. B. At least half the dose should be infiltrated around the wound. C. Can only be given within 1 week of a bite. D. If you are really concerned, can be given intravenously in very high risk cases. Or E. Has to be administered multiple times.
C. B.
The answer is B. At least half the dose should be infiltrated around the wound. Number 3. WHO has strongly recommended discontinuation of production and use of nerve tissue vaccine and the replacement by modern concentrated purified cell culture and embryonated egg-based rabies vaccine. The cell culture vaccine can be given as A. Pre-exposure prophylaxis, B. Post-exposure prophylaxis, C. Pre and post-exposure, D. Terminally sick patients, or E. Obsolete now. The answer is C, pre and post exposure prophylaxis. MCQ number 4. A 35-year-old farmer presents to the clinic after being bitten by a rabid dog. The bite is on his forearm and there are multiple deep wounds. Which WHO rabies exposure category does this incident fall under? A. Category 1, Category 2, Category 3, Category 4, or E. No exposure?
B.
Answer is C. Category 3. MCQ number 5. During a rabies vaccination campaign, a healthcare worker explained that at least 75% of the dog population should be vaccinated to achieve control. What type of intervention is this an example of? A. Primary prevention, B. Secondary prevention, C. Tertiary prevention, D. Quaternary prevention, or E. None of the above?
A.
Yes, the answer is A. Primary prevention. MCQ number 6. A person completes a full post-exposure prophylaxis vaccination schedule after Category 3 exposure. What should be done if they experience another exposure within 3 months? A. Restart the full post-exposure prophylaxis schedule. B. Administer the rabies immunoglobulin only. C. Provide wound care only. Or D. Administer one booster dose of rabies vaccine.
A.
The answer is C. Provide wound care only. MCQ number 7. A man is bitten by his pet dog in Lahore. He noticed a strange behavior in his dog from few days, that he is not eating well, extreme aggression, unusual bark, excessive salivation, and fear of water. Choose the best option regarding the medical management of this victim. A. Patient's life can't be saved with any measure. B. Patient's life can be saved if proper and timely vaccine and immunoglobulin are administered. C. Patient's life can be saved if vaccine and immunoglobulin are administered after the onset of rabies symptoms. D. No use of vaccine and immunoglobulin once a rabid dog bites an human. Or E. Patient's life can be saved if proper and timely vaccine is administered.
B.
The answer is B. Patient's life can be saved if proper and timely vaccine and immunoglobulin are administered. MCQ number 8. Rabies is a vaccine preventable viral disease which occurs in more than 150 countries and territories. 40% of the people bitten by suspect rabid animals are children under 15 years of age. To prevent rabies, which among of the following public health measures are best? A. Kill all the stray dogs. B. Vaccinate all dogs. C. Add the rabies vaccine to the country's immunization schedule. Or D. Capture all the animals that bite to observe them for 15 days to guide medical management. The answer is B. Vaccinate all the dogs. MCU number 9. A 19-year-old frightened college boy came to DHQ Hospital Sahiwal after a minor bite of a farmer's dog in a playground of a college. Upon inquiry, he said the dog bites him when he went near a dog to pick his ball. Dog's owner told him that the dog is not vaccinated. However, the dog is otherwise healthy. He is worried about getting the rabies and wants to get vaccinated for rabies. How will you counsel this boy regarding vaccination? A. All dog bite victims should get rabies vaccine. B. No need of vaccination in minor bites. C. No use of vaccination after exposure. D. Give rabies immunoglobulin to the boy. Or E. Advise him to observe the dog for any illness in dog for 1 week.
E.
Yes, the answer is E. Advise him to observe the dog for any illness for 1 week. MCQ number 10. A 40-year-old man came to emergency at 2 a.m. after a bite of a street dog while he was going to home from the railway station. He got 2 into 3 centimeter wound on his right arm. What immediate step is needed regarding his wound management? A. Apply the sutures and advise him to change the dressing daily. B. Wash the wound with normal saline and apply sutures. C. Wash the wound with normal saline and let it open for secondary closure. D. Apply bandage and prescribe broad-spectrum antibiotics. E. Do not require any management.
C.
Yes, the answer is C. Wash the wound with normal saline and left it open for secondary closure. This is the key to the MCQs. This is the YouTube channel where the presentation will be uploaded. Thank you for your attention.